My name's Michelle Williams. I'm Professor of Cardiovascular Imaging at the University of Edinburgh and Associate Director of the BHF Data Science Centre. And I'm going to be talking about the progress, the background, and where we've got to. Here is our plan today. A welcome and background from me and the where we've got to. Updates from the Scottish Medical Imaging team, early learnings from the SMI data, which I'm hugely excited that we now have access to. I'm going to talk a little bit about the initial planned analysis, and then we've got time for Q&A, and I'd really like your help to help us shape our analysis, so the next steps around that. So without further ado, the aims of the SHIELD-CVD project. So in the United Kingdom, 7.6 million people are living with heart and circulatory disease. Medical imaging tests play a crucial role in diagnosing and managing cardiovascular disease. But routinely performed imaging is currently underutilized in cardiovascular research. In a webinar that we did, a workshop, that we did a few years ago, we identified many of the barriers to that, and there are lots. Sometimes it's finding the data, maybe it's accessing the data, linking the data to the other information, being able to analyze it in a place so that you can do whatever assessments you need, and also just knowing what data is available and where to find it. So that's why we put together the SHIELD-CVD project. The overarching aim of the project is to enhance the Scottish medical imaging data sets, accessibility and applicability for cardiovascular research, so that we can use this as a model for many other data sets that are emerging of routinely collected imaging throughout the UK and beyond. There are a few specific aims for this project. The first is to complete the application and governance paperwork to access this data and make that available to researchers. I'm delighted that we have achieved this, and please do check out the website. The BHF Data Science Centre website has a page all about SHIELD-CVD where you can access this and top tips about how to make a good application. The second is to use the imaging metadata, imaging reports, and linked records to assess the number and type of cardiovascular imaging tests available, imaging sequences and reconstructions, demographic characteristics, and comorbidities for patients with different types of cardiovascular disease or different types of cardiovascular imaging. And very excitingly, for a couple of weeks now, we've had access to the data set, 57.3 million data points, imaging tests, and we're starting to understand what we've got from a cardiovascular disease point of view. So I'm really excited about John's talk today that's going to give you just the most basic headline information that we're going to be delving down to in the next few weeks and months. The next is to develop a reusable code for data curation and analysis and research generation of research phenotypes. Lars has been actively doing this already and will be sharing the code as we're able to on the BHF Data Science Centre GitHub repository. The idea of this is that no one should be repeating the same things and wasting time doing what's already been done. We should be sharing our work to advance cardiovascular research in this area. We're going to do a more detailed exploration of coronary artery disease as an exemplar project, partly because we get asked about coronary artery disease imaging a lot at the moment, and just surfacing that information for researchers will be really valuable. There are many, many other diseases that we could study in this data set, and I hope that the people on this call today will be some of the people who will be doing that. And then finally, to create a community around the use of routinely collected imaging data to share learning and resources. And this webinar is one of several that we've done around this, and we're developing this community around the SMI dataset. So thank you very much for being part of that. So yes, in green, we've done. In orange, we're working on. So that is the end of my slides. So I'm now going to hand over to the SMI team to tell us about updates from their side. So Rebecca and Jamie, over to you.
Thank you, Michelle. If you just give me a second while I share my presentation. If somebody can give me the thumbs up when it's seen.
Yes, we can see that, Gran.
Thank you. Yeah, so myself and Rebecca today are going to give just update a couple of things that have been happening within SMI. I introduce myself. I'm Jamie Kidd. I'm one of the research coordinators within IDRIS team. And myself, along with Rebecca, look after the day-to-day, the sort of projects within that are using the SMI resource, along with Jackie and Rob. And we also do some other sort of projects to try and make SMI more accessible. And so today I'm going to talk about work we've been doing around the de-identification of structured reports. And I'm going to work on the basis that most of you, I want to work on the basis that SMI is new to everyone, because I don't know who's been at the earlier sessions and who hasn't. So the Scottish Medical Imaging Project, led by IDRIS at Public Health Scotland and our partners, is one of the largest real-world research-ready medical image archives globally. So we've got over 60 million radiology exams and around 2 billion individual digital images across modalities like CT, MRI and X-ray. And they're stored in the national safe haven where researchers can build, do the research, build AI models and all sorts with real clinical relevance. So the SMI currently holds a copy of around we've got identifiable images from the national packs from 2010 to 2018. And yes, so we have MRI, CT, PET, radiographs, and nuclear medicine modalities all have been de-identified. These are the images themselves. And we're looking to do the same soon for mammograms and ultrasounds. And we also have de-identified structured reports, which can be provided or used in cohort curation to create new metadata. So, for example, to confirm if a patient has a stroke. So, a structured report, that's the sort of radiologist report that goes if a patient's sent for a scan, then when the images get reviewed by a radiologist, this is their report. And we've also been working with the University of Edinburgh to assemble a repository of around 1 million and growing real-world retinal images. And I just saw a name pop up joining the meeting there from the Scone team. So glad to have them along to this session as well today. So structured reports, yeah. Structured report files are a special type of DICOM file supplied as images, and they're designed for exchanging clinical information and findings. Like sort of standard images, CT and MRIs, structured reports are an image modality in their own right, and we have near 40 million of them within the SMI archive. In the same way, a researcher can define a cohort for their study based on DICOM tag data and body part mapping. For example, all CT chest images that are of the lungs. The cohort can be further defined using structured reports. For example, any CT chest images where showing lung nodules with the presence of lung nodules as text within the structured report indicating this. And this is done by natural language processing, which is a form of natural language. So it's done by natural language processing, which is a form of machine learning. And cohorts can be built directly from these structured reports as well. However, as they allow open text, this increases the likelihood of the report containing personal identifiable information. And therefore, before we can release these reports to researchers, we firstly need to de-identify them. And as I mentioned before, there's several tens of millions of these. So to provide actual reports to researchers, once we've extracted the structured reports of interest from the SMI archive, they're processed by our partners at EPCC through SEMI-HR, which is a pre-developed software designed by the University of Edinburgh for de-identifying medical text, and which has been validated for use in the SMI archive. And it redacts any text it deems to be identifiable and produces a redacted extract. At this stage, all redacted text is considered a true positive, even if false positives do exist. So it's not possible for us to review these extractions. If this software says it's identifiable, then we have to take it at its word. We then undertake a second step here within IDRIS using a software application called isIdentifiable, and this acts as a safety net to detect structured reports with potential items of identifiable data that weren't redacted in the earlier SEMI-HR process. And unlike SEMI-HR, this is not a redaction process, but rather it flags any identifiers within the text and therefore making the full report unreleasable. However, unlike SEMI-HR this time, we can review these potential PII, or what we call as failures. So we can review these failures to actually see if they're true or false positives when it comes to identifiable data. So using the brain as an example, I should have found a chest one or a heart one, but it was a brain one I had on file. So using the brain as an example, isIdentifiable may flag Monroe, a common Scottish name, as being identifiable information. And while that may be correct if the structured report in question is about a member of the Scottish rock folk band Runrig, it wouldn't be the case if the radiologist was investigating the foramen of Monroe, part of the brain's anatomy. Therefore, IDRIS can begin to code rules within this isIdentifiable software. For example, if Monroe is preceded by the word foramen, then we can safely say this is not identifiable information. So to give that in context for the chest, there are around 3 million structured reports for chest CT scans, and isIdentifiable identified that around a quarter of these couldn't be released to researchers. Fortunately, we don't need to review every report, as most failure rules are repeated across hundreds, if not thousands of reports. And we've been able to create rules specific to the chest, meaning 90% of the 3 million reports can now be deemed suitable for research purposes. However, it's not possible to review every report, especially when the failures become unique. So we still have some 350,000 chest CT scan reports unavailable for research. And we don't have any plans to really do any more rules on this, because the time it would take to almost review each of these individually is too long. And this is what we call cutting off the tail. But in future, subject to funding, we would like to enhance this tool for this second step. So rather than it just being that a sort of absolute exclusion process, this too becomes a second redaction step, meaning that we could hopefully release 100% of the structured reports. So yeah, that's a good step, some good progress we've been making, and very relevant to the SHIELD study, as we're able to now start offering structured reports of the chest to researchers. And then I'll pass you on to my colleague Rebecca, who will be giving some more updates of some of the work we've been doing in SMI.
Thanks very much, Jamie, for a really excellent summary of what you've been up to. And the structured reports have huge amounts of useful information on them. That issue of cutting off the tail is one of the ones we're also coming across with our classification of imaging types. We could classify all 30,000 different study descriptions, but we have to draw a line somewhere at the moment from a resource point of view, with the hope that in the future new and additional things will come along that will help with that. So awesome work. Rebecca, please tell us more about the SMI team's work.
Yeah, so hello everyone. Just wait a second here we go, for my presentation to come up. I'm Rebecca, and I'm going to talk to you very quickly today about egressing from the safe haven. So what will a successful egress look like? At a very high level, I know it sounds obvious, but know what kind of model you want to develop. Don't take a let's see what we can create approach. It's really, really important that you think about how you'll be building or training your model and the processing that you'll be doing, because it might not be possible later on in the process to make adjustments or amendments that will allow you to take the model out at the end, and it's an awful lot of time and work for something that might ultimately fail. So do make sure that you're clear about what kind of model that you want to develop. And again, it sounds blindingly obvious, but it's worth saying, please do tell us in advance, and the earlier the better, because we want to be able to egress models just as much as you do. And as we do with all projects, we'll work with you while you're drafting your PBAP application, and we'll help you explain the model or the models that you want to take out of the safe haven at the end of your proposal. And we'll go to the panel on your behalf when it's submitted for consideration. So the more information we have, the easier the process should be. You can make what you want of the pause there, but we will help you with that. So what do we consider? Like any request to take something out of the safe haven, we'll consider the likelihood of an adverse event, and we'll also think about the impact that event might have, just like we would if your request was to release tabular data instead of a model, because the format might be different, but it's the same principles that apply. It's about understanding what information is being exposed, how it could be interpreted, and the risk that that might carry. And we'll have to consider complexity, and as with everything, the complexity can vary. And what if somebody just has the model architecture? Well, if someone did just have the architecture, it's possible that they could test to see if a particular image was used in training, but they would need access to the image as well. So if they don't have that, then that risk is lessened. So what we'll ask is, will having this allow them to find out anything new about an individual? And one thing that we'll consider also is whether a scan itself would cause an issue. And the answer, unsurprisingly, is that it depends. Some scans, like a retinal scan, for instance, are a routine part of care, but there are some, while not indicative of anything in particular, may indicate that further investigation is warranted. So, for example, if you've got someone might have a chest image with no other information on it that shows a shadow on a lung or an anomaly in the heart, and with nothing else involved, it might not indicate much, but it could be possible to make an inference that follow-up of some kind was needed. And then if your model isn't just processing scans, but it's also got access to disease classification, then that could also be an important piece of data that allows somebody to learn something new that wouldn't be possible without it. And that could increase the possibility of harm caused. And just to add a further consideration that we might make, there are some scans that could be present that can allow inference just on their own. So as I understand it, DEXA scans, for example, are less common, and they're often done when there's a suspicion of osteoporosis. So even without a disease classification, if you end up with a DEXA scan and nothing else, you could infer concerns about that condition. It's not a one-size-fits-all situation by any stretch of the imagination, unfortunately. We have found that we've had to consider some technical risks as well. So if you take foundation models as an example, our current approach with that is that we're cautious. So for example, we don't allow releases of decoders from the safe haven. And the decoder is the part of the model that reconstructs an image features. And assuming some level of pre-processing has been applied to the images, it would be highly unlikely that someone could then reverse engineer the model to recover the original images without the decoder. So finally, have we been able to release all models that have been requested? Unfortunately, no, we haven't. We have been able to release some, but we've not been able to release others just because we deemed it was too high a risk. But having said that, even though we've not been able to take all models out of the safe haven, for the ones that are still there, there is still the possibilities that they could be used and made available to use in future projects within the safe haven. But that obviously is still subject to all the same approvals and permissions, obviously. And that's been, that is really a whistle-stop tour of what our experience and considerations have been so far, but we're always learning.
Fantastic. Thank you, Rebecca.
Thank you.
I still think it's fantastic that we've got to a point where you're able to egress some models. I remember we've been talking about this for a long time, and at the beginning, it was an absolute no to taking machine learning models in and an absolute no to taking machine learning models out. So a huge amount of progress has been made to be able to do this sort of work. So the top tip, I think, from all of this is to chat to the SMI team before you start your planning to really get the information on where are things at the moment and could this be possible. And even if machine learning models can't be taken out of the safe haven, there's still value to creating them within the safe haven to be used, as you say, for future things. So it's fantastic work. And what we're going to do is we're going to have questions for all the speakers at the end. So please do start popping them in the chat, any questions that you have as they come up. But I will now hand over to John Nolan from the BHF Data Science Centre team to tell us about early learnings from the SMI dataset. We've had access to this dataset for a very short period of time, but I am so excited that today we're able to actually share some of the information about the dataset itself. So over to you, John.
Great, thanks very much, Michelle. Can I just start with a quick confirmation that the slides are showing on screen, if I get a thumbs up?
Yes, we can see them, Grant. Thanks.
Fab. Thank you. So yeah, thanks again, Michelle. Hi, everyone. My name is John Nolan. I am a senior health data scientist working in the BHF Data Science Centre's Health Data Science team. And I'll start by very quickly introducing the team. There is currently 8 of us in total, and the focus of our team is largely on providing data curation support to a range of projects, making use of linked electronic health records in secure data environments in Scotland, England, and Wales. And from our team, my colleague Lars and I will both be supporting the SHIELD-CVD project in the months ahead. And in fact, it is Lars who's been doing most of the hands-on work so far and who has actually pulled these slides together. Lars is on leave this week, but hopefully I can do these slides justice in his absence. So, as Michelle has just mentioned, we now have access to the Scottish Medical Imaging Dataset. This includes imaging studies taking place in Scotland between 2010 and 2017. And this is fantastic. It establishes a cohort of over 3 million individuals. And for these individuals, we have access to around 20 million separate imaging studies relating to these patients. And yeah, worth emphasizing that the scale of this data, particularly the imaging metadata and a few of the associated linked datasets, is extremely large, which provides some challenges when coming to work with this data. So the SMI metadata has been split into 6 different modalities, which largely represent the nature of the equipment this scan is being done on. So these modalities are computed radiography and digital radiography, which have been provided separately, nuclear medicine, we have computerized tomography or CT, and then magnetic resonance imaging, aka MRI, and positron emission tomography or PET scans. So while the data has been split into these separate modalities, each of these modalities actually have the same underlying data structure that we're working with in the secure environment. So for each modality, we have files containing study level data. And I would think of a study here as essentially capturing a visit to an imaging department. And this study level data captures high level data on things like the modalities that are used in a given study. So worth referencing that a study could contain more than 1 different modalities. The study level data contains information on patient demographics, namely the sex and the age as at imaging date for the patient. And there are also some free text study descriptions that capture more details on the modality and the part of the body being imaged and the purpose of the investigation. The series level data is yeah, each study can comprise multiple series, and the series level data captures different reconstructions or sequences of images, and the series data here contains information such as the specific date and descriptions for the series, again, the specific modality for the series, and then information on things like the body part being examined and the institution name as well. Finally, each series can be made up of multiple images, i.e. the individual slices or frames of the image, and the image file is where the technical details of the images are captured, e.g. manufacturer, model, software version, and more specific image details. It's worth stressing at this stage that the study descriptions and the details of the body parts being examined are stored in free text string fields, and a large focus in the coming weeks will be to summarize what is captured for each image type and to classify and map these to a consistent set of descriptions and labels so that the imaging metadata is easier to query, e.g. to identify a set of images associated with cardiovascular disease, for example. So this slide shows the volumes of patient studies and series for each of the different imaging modalities. So in the case of the computed radiography, we can see that we have data on almost 3 million patients, but this relates to around 13 million distinct studies and around 18 million distinct series. And then not shown on this chart, but again, each of these series would then could then involve multiple images each as well. And it's interesting to me anyway that the relationship between the volumes of the patients and studies and series is different for each of the modalities. So for example, for computed radiography, we have roughly 4 times the number of studies than patients, whereas for CT scans, this is more like 2 times the number of studies to patients. And presumably here there are these differences are driven by the types of imaging and the clinical purposes of these, e.g. some modalities are more likely to have multiple repeat imaging visits for patients than others. With all of these data sets and records in mind, one of the challenges we face so far is the size and the scale of the data. So this slide shows all of the data files that have been provisioned and that we currently have access to, and highlighted in the first instance is the deaths data, which we can see is around 50 megabytes in size. This data is obviously easily read in, and computations in R are run very quickly against this data set. And then similarly, this is generally true for other data sets around that order of magnitude. So for example, the SMR2, SMR6 and A&E data sets. On the graph on screen here, this is showing a log scale. So while it looks like a gradual increase, the A&E data here is actually over 20 times larger than the deaths data set, but at this scale is still rapidly read in, and it's quick and easy to query and process using this data in RStudio. Beyond this, though, data sets are now gigabytes in size, and these files have typically been provisioned across several files with batches either split up by time period or, as I've already mentioned, by image modality as well. So not only do these files require breaking up in storage, this can have an impact on processing times in R. For example, the high-level graphs we're presenting today, just providing counts and frequencies, some of these have taken 10 or 15 minutes to stitch together and summarize this data in R. So when working with this data and developing code, we typically deal with this by working only with a subset of data and then only running this on the full data once the code has been finalized. Finally, we can see that the remaining files in blue, which belong to the SMI image level metadata. This is the largest set of data files, and this is required to be broken up by not just by modality, but by then split into multiple different batches in the case of CT and MRI. This data is now over 800 times larger than the A&E data set that was mentioned earlier. Similarly, the medications data that we work with, highlighted in red here, has also been extensively broken up and presented in 3-month chunks. Just to clarify on the imaging data, although labeled as image, I just want to emphasize that this is the level of the metadata and not the actual image itself. Therefore, these files, what we see when we work with these is the tabular data capturing details of the image, like the make and the model of the device, not the image itself. Again, the modality impacts the scale of the data here. So some modalities don't require multiple files. It's only the CT and the MRI modalities that we see the extremely large volumes of data and number of files for. So one thing we've noticed when working with the imaging data so far is there is a lot of repeated information in the rows of the imaging files, i.e. fields that contain the same value across all of the image records within a specific series. So one thing we might explore is looking how much space we can save, looking at a more efficient data structure and what the impact of this would be on working with the data. So looking at the imaging modalities and the data coverage over time, this slide shows a plot of the number of study IDs per month for each of the different modalities. And now separating these out for a bit of a better view, we can see that the most common modalities are the radiographies, so CR for computed and DX for digital, shown in this left-hand graph. We can see that we have the different directions of travel, which is indicative of the digital imaging replacing computed over time. These modalities have been provided separately in the data. However, in most cases, we would treat these as equivalent, and therefore research projects interested in radiography will likely need to consider both of these image types combined. In orange and blue in the middle graph, we have the computerized tomography and MRI imaging respectively, both of which we can see gradually increasing over the time period 2010 to 2017. And then finally, on the right-hand side, we can see PET scans in light green. And this is the least common imaging type in the data, but it does appear, again, to be increasing over time. Nuclear medicine in purple is the only modality here that appears to be roughly level over the time period of the data. So we expect that most research studies will need to have some understanding of the demographics of their imaged cohort, and the study level data does contain, as mentioned, information on the age and sex of patients, so that this can be easily summarized. We can see that for most of the image types, we see a peak in the age group 70 to 74, and this is especially pronounced for the PET scans. However, the MRI modality seems to peak in the age 50 to 54 group. In terms of the distribution by gender, there is a slightly higher proportion of studies for females in each of the modalities, with the exception of the PET scans, which are more common to the male group. And just to emphasize here that the data shown here relates to unique studies, not individuals. So again, an individual might appear multiple times in this data, and so trends again might reflect that for example, more females have been invited back for repeat imagings and visits. Worth also flagging up at this stage that the computed radiography data does not contain information on age and sex. It's the only modality that we don't have this information available for as part of the metadata. It would be useful to know if this is not available at source, or whether this is just a gap in the provisioning that can be rectified in the data. If the latter, if the former, we might need to link to other data sources such as hospital admissions or outpatient appointments to get the best possible data on age and sex for these patients. Now, in terms of the linked data sets that we have access to, this slide shows the number of patients by month for the SMR data sets that we have access to. So for example, SMR1 being the hospital inpatient records and SMR0 being the outpatient appointments. The linked data sets are not limited to the same study window, which is highlighted in red to 2010 to 2017, that the imaging metadata is. And so we essentially have all available records for our cohort of imaged patients from these linked sources. So for example, the hospital admissions data in orange here runs from 1981 up to almost present day, 2026. And so this data, for example, could be used to look back over a patient's history for any relevant diagnoses and comorbidities, and also to follow patients up over time to identify any relevant health outcomes as well. We can also use these linked data sets to supplement demographic information. So we've already explored things like age and sex, but features such as ethnicity are not available as part of the imaging metadata, but we can identify features such as these from the linked data sets. So on the left-hand side of this slide, we have a chart which shows the distribution of ethnicity codes captured in the SMR0 and SMR1 data sets. And we can see that the most common category in blue is coded as 1A, which relates to white Scottish individuals. But we can also see that the next two most common groups are 99 or NA, essentially, meaning that no meaningful ethnicity data has been captured for patients on these records. On the right-hand side, we can also see that a large proportion of patients actually have multiple different ethnicity codes captured across their records in these linked data sources, SMR0 and SMR1. And presumably, in most cases, this would usually be a mix of a record with a meaningful specific ethnicity code and another record with a code indicating unknown, such as 99 or NA. Building on work from some of the other environments that we're active in, what we aim to do is to develop a harmonized, curated asset for features such as ethnicity that combine and harmonize data from multiple sources so that we can provide the best possible completeness for important features such as ethnicity and to arrive at a single best quality code for each patient. Finally, we can also use the linked data to identify specific disease cohorts, and Lars has been spending time working to establish curated data and reusable code to facilitate efficient codeless matching, e.g. to match ICD-10 codes to the SMR1 hospital admission data to identify cohorts with diseases of interest. And Lars has also been exploring linking this back to the imaging data itself, as in the example chart here, which shows the number of diagnoses of ischemic heart disease over time for patients with a corresponding imaging study within 30 days of the date of diagnosis. So that's a quick summary of our work with the data so far. In terms of next steps, I think, as mentioned, we want to focus on categorizing the free text fields in the study and series level data to provide meaningful and consistent classifications and labels. We want to continue to develop curated assets for key variables such as ethnicity, but also for things like patient location over time so that we can get the best possible indicators of things like deprivation status. We want to continue to develop reusable data curation code that will hopefully underpin future projects making use of the SMI and linked data sets. We also want to explore methods to help work with the large-scale data. So I mentioned looking at more efficient structures for the imaging data, but also we want to make the best possible use of the safe haven itself. We're aware that there's resources for really high for using the large-scale data like the Superdome Flex that we've not explored yet, and we're conscious that we need to test these and for our projects as well. And finally, we want to update these data summaries and explorations to include the more recently provided data sets that we've just got access to, for example, the prescribing data and the A&E data as well. So I'll stop there, but yeah, happy to take questions in the Q&A at the end. I'll pass back to Michelle.
Fantastic. Thanks very much indeed, John. And it's, a huge amount of work from John and Lars to get this starting point of the analysis. As you can see, this is only just the very starting point. They've worked really hard to get information ready for this webinar. And I'm going to talk a little bit about what we're going to do next. As John says, there's a lot of things that we have in our plan. So just share these slides here. So as John's shown you, we're using the metadata of the Scottish Medical Imaging data set, and we've linked it to all of these other data sets. So we've got hospital outpatient attendance, hospital admissions, maternity, cancer, death, and A&E and GP out of hours, and the prescribing information system. Obviously, we would like to add additional data sets in the future as they become available. The census being a one that really has some very interesting cardiovascular disease risk factors within it. And we'd also like to look at the images themselves in the future, but at the moment we're using the metadata. And as has been mentioned, some of that contains reports as well, which we'll be looking at in due course as well. So in terms of what we're doing, we want to help people with the curation and the initial summarization of different cohorts within the SMI dataset that might be useful for cardiovascular disease research, so that it helps kickstart and speed up all the research projects that could be possible in this dataset. And we've divided this into 3 major groups. The first is imaging based. So that is cohorts based on the DICOM data. So maybe my modality, study type, the body parts, the sequences or reconstructions that are available. The second is based on the diseases. So based on the linked data sets using the ICD-10 codes or the procedure codes or the medications, we'll be able to create cohorts of diseases. As you've seen, one example that we've started with is the ischemic heart disease one, which is going to be a very useful and frequently reused cohort, we think. And then also within the text reports, with the fantastic work on the anonymization of the structured data, we'll be able to start working on diagnoses within those test reports as well. And then the third is looking at people with risk factors, comorbidities or cardiovascular disease risk factors based on that linked information. So demographic characteristics, your traditional cardiovascular risk factors like hypertension, but also ones that are often forgotten, pregnancy, cancer, etc. And we'll be able, with the amazing Scottish Prescribing Information System data, to look at cohorts based on medication use as well. So that's dividing the analysis plans into the 3 big buckets. I thought I'd give you a few examples because this is where we really need your help. What are the most useful cohorts for us to put together data curation codes so that you and others can use them? So, for example, imaging-based cohorts. So an example that came to my mind was all patients who've had a CT coronary angiogram. To do this, we're going to need to look at the study description data and identify across people who've had a CT scan what the different words and names for a CT coronary angiogram are in the data set, and then we can bring them all together. So that's a little bit of work that myself and Jonathan Weir-McCall are going to be doing over the next month or so, trying to pull together all the cardiovascular imaging tests based on study descriptions. So CT scans of the heart, MRI scans of the heart, CT scans of the abdomen, all these different things. Then there's the disease-based cohorts. So all patients with a diagnosis of ischemic heart disease or myocardial infarction or pick your disease. Then we've got the risk factor-based ones. So for example, patients with a diagnosis of gestational diabetes and 1 or more cardiovascular imaging tests. And then the combined imaging and disease cohorts. So an example of one here, chest x-rays for patients within 1 year of the diagnosis of heart failure. So these are the sort of cohorts that we're starting to put together. These I've just come up with as random examples, but we'd really like to know what ones that are either you think will be really common and frequently reused, or would be really useful for your research so that we can start creating these for the imaging community. And just a few examples of how those data sets might be, cohorts might be used. There are many things you can do with these cohorts once you have that information. We don't want to do the research on the cohorts. We want to help you create the cohorts. And these are examples of research questions that could be done with these cohorts. And really, the sky's the limit with this. So these examples cover everything from looking at prognosis, diagnosis, medication use, health economics, artificial intelligence, model generation. And there are many different things you can use this data set for. So question to you, what cohorts would it be useful that we curated as part of this data set?